So now, without further delay, let's begin today's event, sponsored by Verato and hosted by Health Data Management. It's my pleasure to introduce your moderator for today, and that is Mike Perkowski. Mike, you have the floor.
Great. Ladies and gentlemen, thank you for joining us on today's program. I'm your moderator, Mike Perkowski. We're glad that you could participate in today's program. Traditional MPIs are dead. What's next? Before we go any further, I do want to take a moment to acknowledge and thank Verato for sponsoring this program. We do appreciate their support. We have two expert speakers today who are going to cover a lot of ground, and I want to get the program over to them as soon as possible. Mark Leroux is Chief Executive Officer at Verato. He formerly was with MicroStrategy, a leading business intelligence software provider, where he spent 14 years, including becoming the Executive Vice President of Products. Before MicroStrategy, he was with Ernst & Young for 17 years, and eventually was partner responsible for technical consulting in the eastern U.S. Mark has MS and BS degrees from MIT in electrical engineering and computer science. We're also going to hear from Joaquim Neto, Vice President of Healthcare at Verato. Joaquim has decades of experience in information management and master data management technologies across a wide variety of industries with a particular expertise in healthcare and in master patient index and health information exchange solutions. He has consulted and delivered solutions for healthcare providers and payers of all types, from Fortune 500 health systems to community hospitals. Prior to Verato, Joaquim worked at Initiate Systems and IBM. So we have two expert speakers, and I'd like to get them started now, beginning our program. I'm going to turn the program over to our first speaker, Joaquim Neto. Joaquim, the floor is now yours.
Great. Thanks a lot, Mike. And thanks for everyone who's attending the webinar today, coming to discuss the next big thing in healthcare data management, specifically in the master patient index space. Just looking at the attendee list for today, it looks like we've got a great crowd here today, over 300 people registered. I see more people dialing in every minute here. We've got good representation, too, across the different healthcare sectors. So we see folks from providers and payers, some HIEs and healthcare technologies and companies as well. So just reinforcing how important a topic MPI is for everyone out there. Today, I'm going to start things off, and I'll just take about 10 minutes or so to explain what we mean when we say that traditional MPIs are dead. I'm going to get into that a little bit. I've got a lot of firsthand experience in this space. And then I'll hand it over to Mark, and he's going to get into the Universal MPI concept and talk about how we really think that promises to change the way we manage patient identity in healthcare. So with that, let's get right into it. Why do we say that traditional MPI technology is dead? Well, quite simply, there's been very little innovation in the space over the last decade or so. So when eMPIs were first introduced in the 90s, and then as they evolved moving into the early 2000s, there was quite a bit of investment in the technologies and processes around MPIs. So my first go around at this, I was part of that in the early 2000s. And we did lots of things that were new at the time, creating various messaging capabilities to support HL7 standards early on. Advancing the ball in algorithm technology, so moving from deterministic matching rules to probabilistic techniques or heuristic algorithms and all kinds of fun stuff, to the more tactical types of improvements. So we created new reports and user interfaces, things to improve data steward productivity. And along the way, we enhanced MPIs to become more configurable, more customizable. We made them able to do almost anything you could think of inside of your organization in some very complicated IT environments. So there was a lot of change for 10 or 15 years, but then the innovation kind of stopped. So some vendors moved on into managing other types of data, things like provider data or terminology, both of which very important, but distinctly different from managing patient data and patient identity. There's tons of effort shifted into analytics and building new modern healthcare applications, which has produced some great things over the last decade or so. But the general notion seemed to be that MPIs maybe had gotten as good as they were going to get, and the assumption was that that was good enough. So, our contention is that that's just didn't end up being the case. So the end result was that we ended up in a position where you could put more and more effort into using existing MPI technology, but you've got very modest returns in your ability to improve the quality of your patient data. So state-of-the-art probabilistic algorithms were doing everything they could do. It wasn't possible to improve on, the best implementations of the Liggi-Sunter record linkage model, for example. You could maybe custom configure an MPI. You could tune it periodically. You could eke out some gains and make incremental improvements in your ability to match patient records. But in many cases, the amount of effort that was required to improve the MPI performance just went up because things were getting more and more complex. So even from a capability perspective, some of the things that we thought were good in the 90s and early 2000s, meaning lots of individual features and functions, ended up being a hindrance. So as these systems got more and more complex, with layers and layers being built on top of what is now fairly old technology, the MPI systems basically just got harder and harder to operate instead of easier. And therefore, it's become hard to get the results that we need out of them. So today, we see that the industry really is begging for alternatives to the traditional MPI approach. As examples of that right now, at this very moment, there are 2 industry-sponsored competitions, matching challenges, that are specifically soliciting innovation in the MPI space. And folks on this call, I'm sure, are familiar with one or both, but Chime has sponsored a competition, and ONC is just starting one up right now with the whole idea on how can we change the way we match patient data, do it much more effectively, and do it in a much simpler manner. Organizations are also recently looking into other things outside of MPI to address the identification problem. So other technologies like biometrics or lifetime ID cards and various types of tokens and using your smartphone to identify yourself and things like that. Even national patient ID is a topic that has been resurfacing recently a lot. So all of this just showed this appetite for wanting to take another run at this problem and solve it the right way. So the reason that appetite's there, at least as we see it, is that no matter where you fit in your organization's org chart, and whether you're with a provider organization or payer or another part of the healthcare ecosystem, there are an increasingly large number of initiatives that rely on having an accurate and complete view of your patient data. And so this is clearly truer today than it ever has been in the past. So we've kind of put up a few of these initiatives. The list is long. There's lots of ways to segment it. But just by way of example, maybe you're working on a CEO-sponsored initiative to manage a series of mergers and acquisitions. You're trying to compete in a difficult market, and you're having to deal with this influx of data. Or maybe your organization is really moving to take on risk and provide better outcomes at lower costs. These are initiatives that are perfect examples of initiatives that just can't succeed without having a complete view of rationalized patient records as you encounter more and more data. On the CMIO side, maybe you have a big initiative to improve clinical decision-making, trying to use data at the center of that and use data to deliver much better coordinated care across a large care team. Or perhaps you're just in IT or an HIM and sort of tactically charged with managing this increasingly large volume of data, and you haven't been afforded the luxury of an increased number of staff despite the increase in data. In any case, no matter where you sit there, our belief is that MPIs should be continuing to improve and help you with this problem, but they're not. They've just been stagnant. So before I get into why we've kind of hit the limit with traditional MPI approaches, we thought we'd do a quick poll just to see the items on the screen here, what really is driving the folks that made it to this webinar today. So Mike, I'll maybe hand it back to you, and you can let people know how to do this real quick poll.
Sure, Joaquin, thanks very much. So ladies and gentlemen, this is our polling question. Our question is very straightforward. What critical strategic initiatives are top of mind for you that rely on accurate patient matching? And you can choose any and all that apply. You don't have to select just one. Okay? Your choices are, and also just to make sure you want to scroll down so that you see all 12 of the possible answers here. Improve patient experience, improve patient health, reduce costs, mergers and acquisitions, longitudinal patient record, clinical and quality analytics, evidence-based interventions, flexible clinical and quality rules, HIPAA security, data feed integration, reduce manual effort, and data governance. Okay, a lot of initiatives there. Clearly, MPI is something that touches on all of these to some degree or another, but please let us know which ones are top of mind for you that rely on accurate patient matching. We're going to let you have just another couple of seconds to go through all those possible answers. Let you select the ones that you believe are top of mind for you, the ones that are most relevant. And then we're going to share the results with you, and Joaquin will give us his takeaway on the results, and we'll continue with the rest of our presentation. Okay, so I'm going to present the results here. And we can see quite a number of these already that have gotten very high answers. Quite a number of them, as a matter of fact, over 50%, with the one that looks like that topping out is clinical and quality analytics at 56%, followed very closely by improving population health by 55%. Joaquin, any particular takeaway on the results you see here?
No, that's great. That's great. We did get this really high results on a number of individual categories there, so that's interesting. I think maybe what we'll do is we'll just ask folks to think about your own answers and where you indicated your focus, and scroll through the list for a second and look at what other initiatives are driving folks to care about MPI and accurate patient identity. And maybe let some folks draw their own conclusions. Like you said, there's a wide distribution of areas that this is clearly affecting across the folks that are on the call today. We'll give you guys a couple more seconds to just scroll through and digest the results, and we'll of course send this out to you in materials as follow-up, and maybe try to paint a picture around some of the stats that we see after looking at it in a little more detail as well ourselves. All right. So why is it that we've reached the limit with traditional technology despite all of these various business initiatives that require better and more accurate patient data? So just starting with a few basics, right? MPIs are at their core using demographic data to match and link patient information. So this means names, birth dates, SSN, address information, right? Very basics. And as you encounter patients in the healthcare system, you build up this collection of attributes about a person, and they come across different times. They come with different degrees of accuracy, and if you've been around MPIs for a while, or if you've just been a consumer of EMR data in any way, you understand that there's significant underlying data quality issues with a lot of the data that's captured by our healthcare systems today. So you've seen the various spellings of the same name. You've seen typos in birth dates and social security numbers. You've seen, crazy, weird address formats that just are impossible to manage, to match against each other. And of course, you've seen lots of just missing data elements, pieces of information that you'd love to have about someone, but that weren't captured during the registration process or on the particular transaction that you're trying to match up with your patient data. So people are familiar with this, but if you look deeper, and we've done some analysis on data from clients that we've interacted with and on sort of larger data studies, and it turns out that a big chunk of the EMR data quality problems, the data that's feeding into MPIs today, and is causing the problem with MPIs not being able to get the right result often enough. A big chunk of those data quality problems are not end-user created problems. So they aren't things that you could train out of a registration staff process, or they're not things that you can see through or capture with a better fuzzy matching technique. There are actual legitimate data scenarios that are caused by real-life events that result in the data being difficult to resolve across systems. So there are things like moving, you change your address. Things like getting married and changing your name. When you look across these types of real-world events, just this moving idea, almost 1 in 5 people have some kind of change that affects their demographic data in this way. Then there's other scenarios, having similarly named relatives. These are the types of things that trip up traditional MPI technology, and there's nothing we can do about it. We can't change the way we capture data to change the name of your brother who happens to be named like yourself. These are just real-world problems that we have to find a way to deal with. And then on the missing data side, there's simple things like having policies that prevent you from capturing social security number. That continues to be a big hurdle in a lot of existing MPI implementations that we see. So the impact of that is that as many as, and I think it might actually be higher than this, 30% of health records have key errors in demographic data that are basically making it not possible to resolve them properly using traditional techniques. And then the end result, the business result, is that there's some pretty underwhelming quality metrics around patient identity today. So many organizations have duplicate record rates that are still just way too high. They're in the double digits. And that's especially true across organizations that have multiple applications, which is the vast majority of organizations have multiple healthcare applications. The financial implications are clearly significant. You can look at it from a sort of claims or from a billing perspective, and there's significant value there being lost because of failed identification that records between systems. And then this last point here is a fairly astonishing stat that 86% of healthcare professionals know of firsthand clinical events, adverse clinical events that were a result from poor record matching, or events that could have been prevented if the right answer had been obtained by the MPI. So that's one that maybe I'll let sink in for a minute. That's a big one. The clinical impact of having accurate patient data is always one of the fuzzier parts of an ROI or justification for investment in MPI. But it's clearly one of the most important. So as difficult it is to measure the clinical impact, time and again we find that organizations committed to the ultimate quality and care delivery often come back to that patient treatment quality and safety as a big driver for continuing to improve in this patient record matching and reconciliation. So we just looked at those stats that kind of paint a sort of dismal picture of where we are today in general, and that's despite lots of effort being made, at least across some organizations, in and around MPIs. So people are allocating lots of resources, data governance committees to decide on what matching algorithm rules should be, IT teams to build and constantly maintain MPIs, so upgrading to recent versions, implementing new features in algorithms, doing tuning exercises, and then data stewards whose day-to-day job is full-time, basically cleaning up all of the issues that can't be automatically prevented by the MPIs, which is what they were put in there to do. So that current state picture gets a little worse if you look forward, or maybe it gets a lot worse. So if you at least especially think about the economic impact of where the industry is going and the move away from fee-for-service care delivery, as organizations take on more and more risk, which is clearly a trend that's happening with the number of lives covered by risk-based agreements only going up, then the actual financial incentives, along with the altruistic care delivery incentives, those go up significantly as well, because fragmented patient records are a huge hindrance to being able to understand risk of various patients, to be able to understand how to treat those patients given their conditions, and how to coordinate care across the number of people who are trying to manage their health outcomes with the lowest costs. The last thing as we look forward is, as you think about how things are changing over time today, is that the complexity of the systems are continuing to grow. We touched on this before. But as organizations invest in new applications means more data. And the number of healthcare initiatives out there that are really seeking to change the way we deliver healthcare are requiring new systems to be put into place. So if you have a population health initiative, you've probably got a population health application or analytics solution, and that's more data you have to manage. If you're implementing a digital health or a telehealth program of some kind, that's a big chunk of more data and different data than you've seen before. If you're trying to engage with consumers directly and having consumer apps that consumers can work with on their own, again, more data sources. So more and more data sources are coming. The impact of not rationalizing that data is big based on where the industry is with a risk-based care. And finally, all the IT effort around these new data sources is only going to be growing, and the demands to get the patient data right underneath all that are just getting higher. So given all that, our premise is that conventional MPIs are not keeping up with that. We need to find some better way to do this. It simply takes too long and is too hard to implement them. They're too brittle and can't keep up with the changes without lots of tremendous amount of effort. And then as the data volume is growing, the problem is of the underlying data is just becoming something that can't be properly managed by traditional MPIs. So what's next? I'm going to hand things off to Mark so he can tell you about this idea of universal MPI and explain how it can meet today's and tomorrow's patient identity challenges. So as I do that, you might just think, to put this in perspective, there was a first generation of MPI technology, which was basically a common index that was used by several applications at once. This is the type of thing that you may have seen, embedded in an individual EMR, the basic MPI capability you need to operate against patient data. Then the second generation, we got enterprise MPIs, and these gained traction, at least for organizations that had sufficient resources to invest in them, but they became quite complex. The benefits haven't been fully realized, and there's just too much effort required for those to be the answer. So we're looking at a third generation of MPI, and we expect it to be a modern solution that truly enables identity interoperability within organizations, across organizations, and irrespective of how big or sophisticated your individual IT shop is. So that's what we're looking for in Universal MPI. And Mark, I'll hand it off to you to explain what we think that can look like.
All right. Thanks a lot, Joaquin. So thank you, everybody. Thanks for being on this webinar. Really appreciate it. And Joaquin, thank you. You gave a good persuasive argument that the existing MPIs have probably about reached the limits, their peak of their performance, and that status quo wouldn't be bad except for two major changes that are afoot that are going to disrupt the status quo, that being the fact that there are going to be much more demands on the MPI for matching from many more systems, and secondly, that there's much greater or more severe economic impact for lack of patient matching. So those two things are upsetting the status quo, and we're making the premise here that there's something different that ought to replace the traditional MPI, and we call that thing Universal MPI. And obviously the question I'm here to answer is, what is a Universal MPI? What would it look like, and how is it different? So to explain that, or to describe it, let me take one small step backwards and just put up this very simple equation that describes the problem of patient matching, which is that patient matching is really just equal to some combination of the quality of the data that you're working with and the sophistication of the algorithm that you use for matching. So what that means is if your data quality is perfect, then the algorithm can be very stupid. It can be very simple. But for every element or every instance or every degree to which your data quality is not good, is degraded, then the algorithm has to be more and more sophisticated in order to get the same patient matching. And that's a fairly easy concept to understand, but it is two free variables. You can work on either one of them to try and solve or improve the problem of patient matching. Now, Joaquin said that 30% of the demographic data that is existing in healthcare data sets, and frankly, in other industries based on our analysis, exhibits about 30% error rates. And the question at hand is, going forward, how is that error rate going to change? Like, what does it look like? Whoops. Obviously, biometrics, as they become implemented pervasively through healthcare systems, will only improve the quality of data. But the question is, how much will it improve the quality of data? That's really the question at hand. And quite frankly, it's our opinion that certainly biometrics will improve the data quality at every point of patient interaction, right, at the point of capture. But it probably isn't going to have a big impact on the billions of records that already exist within MPIs or databases. And equally, for biometrics to be truly useful, they have to be pervasively deployed. They have to be at every point of patient interaction. But nonetheless, it looks like a great technology that ought to help with data capture and improving data quality at that moment of capture. But on the downside, we really have to face three hard facts, one of which is just that a basic premise of data science is that as you aggregate more and more data from more sources, the quality of the data only degrades. Like and it degrades at a compounded rate. Each new data source has an increasing detrimental effect on the quality of the data that pre-existed. And I guarantee you that the owners of MPIs today are going to rightly resist new systems connecting up because they know that every new system is going to create a degradation for all the previously existing users. It's just and it's not anybody's fault. It's the nature of data and the level of technology we have to work with it. Secondly, we all know that if the data is degrading, the way you compensate for that is to pour more emphasis or more effort in trying to cleanse it or govern it or standardize upon it to make it work better, to make it be a better set. But anybody who's lived on or worked on a data governance committee knows that the more people on those committees, it gets geometrically more difficult to work the committees, to get the compromises necessary to improve data pervasively. And thirdly, another basic idea within MPI systems is that when you go through all the effort to find the correct data, find the golden record, establish the best attribute for a given person through the MPI process, you often want to push those data corrections and data updates down through all of the source systems so that each subsequent matching exercise is easier. But again, with more and more data sources, the effort, both mechanically, operationally, and politically, to push corrected data back upstream makes the problem, again, exponentially difficult as the number of sources increase. So we have a situation where data quality inevitably is going to be going down in the near future. And you look at that with the backdrop of the fact that what Joaquin mentioned, that probabilistic algorithms have reached their theoretical limit of matching capability based upon pure mathematics, we really have found ourselves in a really unhappy situation, which I can redraw this way. If today we have status quo of data quality at a certain level, with sophistication of algorithms and data governance at a certain level giving us an adequate matching, tomorrow we have a different situation. We have degraded data with lower quality. We have flat innovation, ultimately resulting in a degraded matching capability just at a time, as Joaquin mentioned, when the economic impact of bad matching is going to be at its highest. So what we would propose, and the premise of this webinar, is that there needs to be a new formula. There needs to be a new set of technologies affecting this equation. And that the new free variable that we have to work with is the application of big data, of establishing a big data solution that can act as a backdrop or a template for all of the patient data that we have, and which can also act as the fuel for a new kind of matching, which we've labeled here as referential matching. And it's the combination of those two technologies that we are referring to here in this webinar as a universal MPI, or a universal reference database. And let me show you more about that. In fact, the three major components of a universal MPI are these. Number one, it's a pre-populated database, a reference database, if you will, that contains identity data, demographic data, spanning all possible patients. So it has to be a nationwide database of highly curated referential data about people. The second big component of a universal MPI would be this new referential matching architecture that uses all of the benefits of probabilistic matching, but extends them beyond that to take advantage of the big data reference database. And probably most importantly, it's obviously more accurate. I've mentioned that already, and I've got a slide coming up that illustrates why that's so. But probably most importantly, this new kind of matching, this referential matching, has to require an absolute minimal amount or virtually no tuning, because as you're bringing on more systems, if you had to retune your MPI for each new system, that obviously is going to slow things down to a crawl and wouldn't be nearly as nimble as what the requirements would demand. And then thirdly, this universal MPA has to be cloud-based. It has to be cloud-based for scalability reasons, so that organizations can simply plug into it rather than going through the whole effort of install, setup, tune, patch, configure, test, capacity manage. All of that are technical drags on the dynamic nature or the nimbleness that's necessary for the future state of master-patient matching. So let me talk about each of those three components, each one in turn. I'll give it a slide's worth of real estate, maybe 2 slides in some cases, just to set your expectation. But let's talk about the reference database first, because this is the core. It's the foundation of the entire universal MPI idea. And what this reference database has to comprise or be composed of is a number of very, very credible data sources, very big, very extensive data sources. Listed here, I've listed credit and telco and governmental legal as 3 examples, but the characteristics of these databases is that they are nationwide in scope. Very large proportions of the population participate in the credit processes, in telephone company subscriptions with your mobile phones or your landlines, and in interactions with the government. So they're very extensive, and people have a vested interest in making sure that their identity data that's in these systems is correct. They want their credit. They want their telephone system to work, or telephone number, and they want the government to give them the dog license. So all of this stuff has 3 very good characteristics, these kinds of data sets, and that's precisely the kind of data needed to populate the reference database. In fact, it needs to be billions of records so that each individual in the database has a dozen or so records associated with them in particular, so that all the evidentiary information about their identity can be assembled together into a large, comprehensive picture. And in fact, it's not just collecting the data, but you need a team of data scientists and data science processes, not just to house the data, but to assemble all of the identity fragments, all of the information, and apply it to the correct individuals. And this is no small feat. In fact, the amount of data science necessary here far exceeds anything which could be assembled by an individual hospital system or an enterprise whose business isn't data itself, whose business is healthcare. And ultimately, what you end up with here, with this universal reference database, is a database that will contain over 300 million, maybe 350 million people if you include both living people and deceased people. It would contain a history of their data, so not just the current snapshot, but entire history of their identity attributes, a history of their name changes, a history of their address changes, a history of any of their changes, to create that constellation of identity elements that Joaquin showed you earlier. And indeed, one final important thing is that this database would be evergreen. It would be constantly being updated with millions of, tens of millions of updates every month to track the changes in the population. And so this is a very, very important and the fundamental core component of this universal MPI idea. But the real question is, once you have this reference database, how can you use it for an MPI purpose? And the first step to the answer to that question is, how do you use that referential database to do better matching? We're not talking about data cleansing here. The reason for that database isn't for data cleansing purposes, it's really for matching. And to illustrate that, I've got this slide here in front of you, which describes probabilistic matching that exists in our current population of MPI products today. And then referential matching is shown on the right-hand side. And what I've used here to illustrate the matching capability, I've used the constellation model that Joaquim introduced, where each identity is represented by that little geometry, either the green geometry or the red geometry in database A and database B. But those are intended to represent individuals, and the different spokes coming off the center identity are the attributes that we've got about each of those individuals. And so we might have a name and address for a person, and a slightly different name and a completely different address for that same person in B. And the way probabilistic matching works is it does pairwise matching. It compares both of those identities to each other, attribute by attribute. And if there's enough overlap in the individual attributes, or if there's differences that can be explained probabilistically, the matching system can declare those two people to be the same person. But as illustrated in this case, if the identity data is distinctly different, or if it's incredibly close but they really are different people, the MPI probabilistic matching system is going to fail to match people that rightfully should be matched. Take those same two individuals on the right-hand side with referential matching. We have the same two geometries of identities, so they're distinctly different from each other in A and in B. But because we have that same individual in the universal reference database down below, and we have not just a small snapshot of their identities, but we have their entire identity constellation, when you do the matching here, you can see that A will match to its appropriate elements within the constellation, B will map to its appropriate elements within the constellation, and even though A doesn't map to B at all, because they both map to the same person in the constellation in the universal database, then they match each other. So this slide, with all of its simplicity, describes the power of having that universal reference database with which to do the matching. And in fact, if I was to dig it one level deeper, and I'm not going to go into this in detail, but suffice to say, there are 4 specific areas where this referential matching truly shines above pairwise probabilistic matching. The first one is probably obvious to everybody. You can see through sparse data. 2 sparse sets of attributes for identities being compared to each other almost never match just because of the sparseness and probability. But with referential matching, you always have a very robust identity constellation with which to match, and so sparse matching is much simpler. Similarly, since the universal database contains lots of data about people, it can see through errors much more effectively. Because it contains a whole history of time, it can see through time just as easily as it can compare current identity elements. It doesn't care whether somebody's address is 10 years old compared to their address today, because the constellation, the reference database, has all of that data in it. And maybe the most powerful aspect of this referential matching using a universal database is the fact that it can do this thing called match by exclusion, which is simply another way of saying it can look, even if it has partial data about somebody that's highly corrupted or error or suspected to be error prone, because the referential system can search through the entire database of 300 million people, it can determine that even though the data is somewhat sparse and possibly incorrect, it can determine that there's nobody else close. And therefore, it must be Mark LaRoe that we're talking about, even though we've only got Mark LaRoe and his zip code. There's only one Mark LaRoe, or anything close to Mark LaRoe, that's ever lived in that zip code for the last 30 years. It must be him. And that's an incredibly powerful concept, and entirely within the realm of this universal MPI, universal matching idea. And in fact, benchmark tests, and I won't go into this in much detail either in the interest of time, but benchmark testing comparing eMPI technology using probabilistic matching with uMPI technology using referential matching, using a very robust data set test, 3.1 million identities being looked for in a body of 44 million identities in the database, the conclusive match rate was starkly different, 70% with the eMPI, upwards of 98% with referential matching. And then the third thing the third thing which makes up a universal MPI is the fact that it needs to be cloud-based. In fact, being cloud-based allows it to be implemented much more quickly, so weeks, not months, using one person, not 4 people. And in fact, it's not just the speed of implementation. In using the system when it's cloud-based, it can be incredibly simple, being accessed just by open, modern APIs. In fact, there's all the discussion today about we're entering an API economy, right? And more our systems are being driven, powered by external APIs offered through the cloud. This is no different than that. Of course, it would have to be high trust, certified, and HIPAA compliant. And in fact, being part of this cloud-based environment allows it to be highly scalable, right? Hundreds of millions of identities, growing easily in volume as necessary, and also providing very high-speed response simply through the elastic scalability of cloud systems. So these 3 big things make up the idea of a universal MPI. I showed you about the database. I showed the matching is better, operating within the cloud. The final piece I have to tell you before the webinar concludes is this slide and the one after it, which really describes how would it work. So how does this work in an MPI context? And so I've got a bit of animation here that should illustrate it, at least at the first level. On the lower left, what you see is the lab, our 3 systems, perhaps a lab system, an EHR, and a pharma system, all of which want to be, have their own patient identities. They want them to be integrated into a single consistent MPI. And instead of buying an MPI, putting it on-premise, and going through all of the integration and tuning exercises, with a universal MPI, what you would do would be submit all of the identities and map them to their corresponding identity within the universal database. So every identity in the lab system, in the EHR system, in the pharma system would find their counterparts in the universal MPI database using that referential matching capability. And once they were tied, linked, if you will, to the universal identities, then the universal MPI would take those identities that were submitted and organize them, link them, according to how the universal MPI has linked people. Okay? And in essence, what that would create would be a virtual MPI for those 3 systems, for the hospital system participating in this. And the interesting thing to note is all of those patient identities that are living in the virtual MPI, they can continue to contain the existing identity data that was captured in the lab system or the EHR or the pharma system. We don't need to change those or correct them or push those changes back down into the core systems, so long as they're all linked to their corresponding universal identity. As long as those linkages exist, then all of the information that lives in the universal MPI is imbued with the patient identities that the hospital system owns and participates in the matching process. And then to finish out this story in its full glory and its full power, we have to remember that the universal MPI is receiving constant updates, millions of updates per month about the identities of the individuals within that reference database. And those identities come in and they touch, 1/10 of the population or 5% of the population every month, but these people are getting their identity data updated through other processes, not hospital visits, but through other mechanisms. And the important thing to note here is those updates don't remain just within the universal MPI, but the advantages of them, those updates, because of the linkages, bleed over or fill up the virtual private MPI also. So the private MPIs take full advantage of this continual identity data update. So this slide might be the most important one in the deck for individual organizations. It shows you how to get up and running with a virtual private MPI within a universal MPI cloud much more quickly, much more reliably with better matching. Now the question that I always get in speaking with clients is, if I'm not ready to replace my MPI, or if my MPI is too wired into existing systems operationally that I can't conceive of unplugging it anytime soon, is there something that the universal MPI can do in order to help me with my existing MPI without full replacement? And the answer, fortunately, is yes, and that's what's shown on this next slide. And on this next slide, what you see at the bottom is the typical MPI situation. People are presenting themselves to systems on the left-hand side. They're going into the MPI to be adjudicated to figure out the same person. And if those two people, Mr. Dark Blue and Mr. Light Blue, can't be correctly distinguished within the MPI with high confidence, then what the MPI would typically do would send a task over to data stewards who would manually resolve that identity, filling up the task backlog and eventually getting to it and putting in the correct answer, but through manual process. And what I'm here to tell you is that with a universal MPI, that same task, instead of going to the data stewards initially, could just as easily be sent to the Universal MPI, where Mr. Light Blue could be found within the Universal MPI database. Mr. Dark Blue could be found within the Universal MPI database. And if they both point to the same person there in North Texas, then the Universal MPI would declare these two people are indeed the same person, and that task never has to go to the data stewards for manual review. They can review the harder solutions or the harder problems. And what this ultimately results in is the Universal MPI acting as an automated data stewardship system for existing MPIs, basically increasing the capacity of data stewards by a factor of 4 and decreasing the time of delivery down to seconds and minutes instead of hours and days. So it's a very powerful concept for improving existing MPIs. And now probably the most interesting long-term and important vision for this universal MPI concept is not what it does within the four walls of an organization, but what it does to connect organizations. And let me show you what I mean by that over these final two slides. Here's a situation where we've got a hospital system and HIE both independently using the Universal MPI. They've linked their patients to the Universal MPI universal identities and are operating perfectly fine in their isolated environments. But if these two organizations at some point wanted to begin sharing patient records with each other, if they wanted to find a patient, if one system wanted to see if a patient existed in the other system, they could do it using the traditional model whereby each one would send to the other some attributes they have and they would do an independent lookup on each side. But if they were both hooked to the universal reference in the middle, then simply by virtue of being connected to the same universal identities, they have the easy possibility of referring to the same patient with each other using a very unambiguous, deterministic identity. They've already gone through the work of linking their individual patients to the universal identities, and everywhere the same universal identity is being used, both parties can be assured that they're talking about the same person, the same patient. And this is just an extraordinary benefit of having such a highly curated, highly defined, well-designed universal reference in the middle with good matching technology. And obviously extending this idea beyond just two organizations sharing or referring to identities with each other unambiguously, you can think of the scenario where it's not 2 or 12 or 20, but it's 100 or 1,000 or 2,000 organizations all using the same universal reference for the MPI functions within their four walls. And as a stunning benefit of having done that for their own inside four walls purposes, they can also then begin immediately, with very little effort, begin referring to patients with amongst each other, transferring patient records to each other with unambiguous sureness. And obviously what we're replacing here is a scenario whereby each system has to do matching within its own four walls, with its own MPI, which we already know is imperfect. In this model, everybody does much better matching with the universal MPI, and then by the transitive property of having matched to the same person, they've matched to each other. I think there's a Euclid theorem on that. So this is a stunning idea, and it really does raise the idea and the opportunity for an identity resolution utility, and in a lot of ways obviates the need for a nationwide patient identity card. This is in essence a surrogate for that fundamental idea and that fundamental solution, and that's a very big idea. So with that idea in your mind, hopefully a bit of excitement, let me summarize what I think we've told you today so you can tell your colleague down the hall what an interesting webinar you just attended. So first of all, the situation that we set up for you is this. We told you that these MPIs that have existed now for more than a dozen years have been essential components in healthcare IT systems, and they've done a very good job, but they are inherently limited. They're limited by the data that they have to work with, and they're limited by the algorithms that they're built upon, and these algorithms have theoretical limits. The complication with all of this is that the status quo is changing. The demands for patient matching are going to increase very dramatically in the coming years. Much more difficult, and it's going to break the MPIs. And at the same time that it's breaking the MPIs, the economic impact of non-matching is going to be much more important, and it could very well become, CEO, CMIO issues again. So therefore, a new architecture is needed. Something new is needed because the status quo just can't work. And what I've told you is that what's needed is this concept of a universal MPI based upon big data of a highly curated set of identities upon which everybody can match and match much, much more accurately with no tuning. And then, of course, the other final and really important point is that this structure not only solves the inside the four walls problem of matching identities between systems, but it also addresses the broader need for a national patient ID, but without the need for a card. And that, by the way, is I believe, the first practical solution to this politically and logistically challenging problem, yet the one that everybody's talking about now. Now, with that, we are concluded, and I see we've run up to quite close to the end of the hour that we've taken up from your time. I hope it's been very instructive to you. We're not really going to have time for the questions. In fact, what I'll offer to, in fact, I see that there are dozens of questions, and some of them are quite good. What I'm going to offer to everybody on this line who's here, or maybe who's not here but who registered, is to answer all of the questions in written form and email them out to everybody, because I don't want to leave questions unanswered. So many of them are so good. But Verato as a company, we're committed to seeing this vision of a universal MPI happen. In fact, the entire company revolves around that promise, and we're dedicated to doing that. And if you're interested in finding out how we do that, just visit our website and begin the dialogue there. So Mike, thank you very much for hosting us. It's been a pleasure.
Absolutely. So I want to thank Mark and Joaquim for their presentations. And as you heard, the folks from Verato will get back to you with answers to your questions as soon as possible after this event. I do want to also, once again, acknowledge and thank Verato for sponsoring this program. We really appreciate their support. And last but not least, of course, we want to thank all of you who attended this program. We're glad that you could take some time out of your very busy days and listen to these presentations. We hope that you got some really good insight and actionable ideas out of this. We hope that you will join us for a future web seminar brought to you by Health Data Management and its sponsors. Thank you all again for being with us today. Have a great day, everybody.